I'm basically a professor of cancer surgery. Spent about 31 years in a regional cancer center in Bangalore, that is Kidwai. Currently, I am working as the Vice Chancellor of Enapaya University, Bangalore, which is a medical university. I chose this topic intentionally because as a surgeon, I would be more happier to talk on the cancer surgery topics. But as things stand, I thought we should explore the possibility of improving the standards of our education in cancer in India. When I tried to do that, I thought it is the right forum to interact with people all over the world to see where we stand. As I said, this is more of an introspection of mine and going around the country for the last 3 decades. The subject of cancer surgery is not new. All of us know about it. But the radical surgeries came into existence only in the 18th century, and in the 19th century it stabilized. But the status of educating formally started very, very recently. In the past, mostly the general surgeons were doing radical procedures, and most of them were autodidacts, I should say. But presently, we have in India 2 types of programs. One is the fellowship program of 2 years duration given by many of the institutions. The next program, which came last 25 years or so, is Master of Chirurgia. That is a 3-year program given by the universities, and the Diplomat of National Board program, again for 3 years it is going on. And the only issue what we will have to see forward would be where do we stand in this such programs, and is there anything called as ideal surgical program for us? For that, we'll have to quickly see what is surgical oncology per se, because different concepts, different people think in different ways. Some of the countries don't even have a discipline called surgical oncology because the subspecialty of the surgery taking care of the concerned organs as the cancer surgeries go on. Whereas in our country, surgical oncology came into existence as a separate specialty recognized by Medical Council of India way back in 1970s. Earlier, they used to talk about performing unique and complicated surgical procedures, leading the fellow doctors and establishing high standard of care and a multidisciplinary approach, etc. But today, we will have to have a review of that, particularly with the surge of multidisciplinary approach coming in from radiotherapy and medical oncology, for example. And one more question that crops my mind would be, is there really training in surgery and teaching in surgical oncology one and the same, or it's totally different, or training is part of the teaching and teaching is part of the training? I really don't know after completing 3 decades as a professor, because many of the training process in surgical oncology today, when it is curriculum based, concentrate more on the curriculum rather than going on for the operative surgery alone as was what you would have done as a part of the training. The objectives of the surgical oncology training, should it be around only this like any other place, like aptitude and communication abilities and skills and knowledge, or we have to concentrate particularly on the patient care, surgical skills, comprehensive knowledge, and leadership skills? Presently, the One Guide, One PG program was going on for about almost 3-4 decades by MCI, but currently that 1 PG, 1 Guide ratio has been changed to 1:2, and now they are moving on in MCH level 1:3. Why I am specifically saying that is, are we trying to dilute the issues by making more numbers, compromising on the quality? This is one simple ratio I'm telling. As we go on, we'll see why I'm talking about the quality being compromised. Second point would be, as far as the training is concerned, it was unit based like any other surgery 1, 2, 3, etc. Now it is moving towards service based, like organ oriented, like breast services, thoracic services, head and neck oncology, etc. And the duration of training is again a matter of controversy going on, I would say, because still the trainees expect more number of years to be spent, although they are spending now 3 years in the training. And in the past, as I said, general surgeons, gynecologists, ENT were doing it. But now, presently, there are 23, as on today, 23 DNB seats across the country and 53 MCH seats available, recognized by Medical Council of India across the whole country. Apart from these two curriculum programs, there are several fellowship programs which are 1 year and 18 months programs are going on at several institutions. Which one of the two we will have to take is another issue the trainees go through. This is one paper I would like to attract because this actually compares India with other countries. These are modified by me because he has compared the author, Dr. Chandra Ray, who is a professor at Nebraska University, who is a cancer surgeon like me, has compared India with other countries, but he has not compared like developing and developed, etc. He has taken HDI as the most important thing. HDI is Human Development Index. The whole Human Development Index is one yardstick developed by UN, taking into consideration the number of years, average age, per capita income, and educational status of the country. And they have divided them into low HDI, middle HDI, and high HDI. And India and China, where I have compared first in this first slide, they come under the middle HDI. For example, the Nepal is in low HDI. Obviously, Australia, USA, and Netherlands, which I have compared, are in the high HDI group. If you see this particular slide, you will be able to appreciate not only the number of physicians, but the inhabitants per physician. You can see the comparison here. And in fact, I was surprised to see when China has got only 526 versus 1 physician, whereas India is still 1400 versus 1. But the duration of surgical oncology education, if you see, again you compare, we are around 12.5 years after the schooling. It comes to 12.5 to 13.5 years, whereas in China it is 17 years, whereas in US it is around 15 to 17 years. That is the number of years one has to go through before coming out as an MCH or DNV saying that I am a qualified surgical oncologist today in the country. This is another paper by the same author, which I have co-authored by me, is where the cancer care and education in US and India, when we compared, you will see the number of fellowships and the trained here per year. Surgical is around 50 in US. At that point of time in 2006, this is 2010, it is 16. Now it is actually doubled. It is more than doubled here. And here medical and radiation, again, it was 441 versus 20. Now again, this is doubled. Radiation, 279 versus 52, it is actually tripled. So as on today, we have got 150 postgraduates coming out in radiation oncology, whereas around 50 coming out in medical. As I said, around 53 plus 20, I said about 70 coming out in surgical oncology. This is the number when compared to what is happening in US per year, how many are coming out with a proper training through a curriculum which they go out. In this particular paper, we were trying to ask a few questions. Mainly, is there a need for a bridge course? What is that I am talking about? Bridge course is, many of us in surgical oncology know who are doing from head to foot. The younger generation is finding it difficult whether to go through the whole area of head and neck, thoracic, breast, GI, or you will do that and then specialize on only one organ system like thoracic or breast or head and neck, so that a bridge course can be brought in to overcome the problems of number, which is less, at the same time the need for staying for a longer years from head to foot. That also was discussed. And also we were talking about what is a comprehensive program when you are talking about cancer education. Is it only the technical skills, or the person has to go through the surgical screening clinics, cancer registry, data management, and the other academic programs, mainly concentrating on research-oriented publication presentation. Why I am talking this is, Both US and UK, which I have visited, concentrate on these two only, research oriented, and the research outcome is measured by publications and presentations and in index journal citation, etc. But in India, even today, we try to go around talking about the knowledge and skill based on these basic sciences, the surgical training, then they go through an array of medical oncology, radiation oncology, pathology, psycho-oncology, community. We still concentrate on that. And now, as I said, in the service-oriented, we are moving towards head and neck, thoracic, etc. The training goes on that way. Whereas in the West, they are still concentrating on research and the research output in the form of publication and presentation. Which one of the two we are going to take, I do not know, because the needs of the individual geographical area may vary. Whereas in our country, more and more surgical, medical, and radiation oncologists, more clinically oriented, clinically trained, are what is going on in the formal training, in the curriculum-based training going on in the country. When it comes to the surgical training, for example, whether we are going to ask the person to perform during the training independently or assisted or supervised. Why specifically I am saying that is, if this is done, the problem would be the patient safety may be compromised, is what we always are worried. But if it is not done, the trainee has never trained during his course, under supervision if he has not done, under guidance if he has not done, when is he going to take up the knife is another issue. So this dilemma goes on with more and more medical legal cases coming in, and no formal medical law as a single law in our country. So this becomes another problem of subjectivity rather than more objective. He is more of observer, more assisting, and he may be doing a few things, but he is expected to do big and bigger things in surgical oncology during 3 years, which becomes an issue when you are training with respect to the patient safety. However much, whatever protocols you write or you do, actual performance is by when the trainee is performing, and the trainer, even if he is standing on the other side, there is an element of questioning regarding this point, that is patient safety. If that is the only way, if you are going to look at it, the training per se will be compromised. I do not know how we are going to balance these two. Over a period of time, one more problem is occurring is the evolution of surgical oncology as a whole. From radical surgery, today we are moving in the last 30-40 years to organ preservation. And from open surgeries, we are moving to minimal access. And we are now, right now in India, we are talking about robotics, and robotics have come in big way in many of the centers in India. And hence, we were looking at the lacunae first, the lack of uniform training patterns in our country. Although the curriculum is there, syllabus is there, which is recognized with universities, board, Medical Council of India, but they are not the same. I have been an examiner from all the centers in the country. For example, Gujarat, Ahmedabad, there is a different way of training, whereas way back down in Chennai and Bangalore, the training is different. But the curriculum is the same, syllabus is the same, but uniform training process is not there. And there are various definitions of surgical oncology. What I mean is, in some places, head and neck is inclusive, whereas in some places, head and neck is exclusive. They go out. So the surgical oncologist trained in one particular center would not be seeing head and neck cases at all, whereas other centers, they do so much. And that is going to create another problem. So that requires uniform training pattern is what I am talking about. And the variety of providers that perform cancer surgery. That is the most important issue here from the trainee's point of view. The variety and is so much, so many, they try to catch with them is difficult for them from their point of view in 3 years period of time. However much the number would be, the turnover would be of the institution, from their point of view, we are going to have a problem about this variety. Having said all this, the confusion here for me after 30 years would be this training after surgical oncology, we may have to train them further. After doing everything, whether again he has to go to a sort of apprenticeship to have what I was going on stressing, a skill-based training where it only concentrates on operative surgery, etc., rather than as a whole academic training which goes on in the last 3 years. And we have to be clear about the endpoints of a training program. Are we training our trainees to go and perform surgery or treat patients as a whole, or are we training them to become teachers? This clarity is not there, because it will definitely vary. As you know, they have to be trained as a practitioner or they have to be trained as only academicians is one another issue. And the policy making is not in our hands, but in India, it is Medical Council of India which regulates the whole thing as far as medical education, including surgical oncology education in India. So we have to sensitize the policymakers on these issues, and there is no way there is a feedback mechanism to go about doing that. The last problem, as I was repeatedly telling, is so many MCHs come in the last 3 years. For example, MCH surgical oncology was going on for 30 years. Now, head and neck oncology has come, gynec oncology has already come, and people have started talking about MCH breast. And I have jokingly written that one fine morning MCH robotics and MCH laparoscopy will come. When this comes out, so the body has been segregated so many divisions, then the role of surgical oncology as a whole, according to me, goes down. So where does it stand? I do not know. But the innovative modules, if you are talking about it, and more operative hours for the individual units and the trainees, and a proper surgical assessment, as I was telling, whether he is safe enough to go to the public, is what is now. Surgical assessment is not going on. It is more on paper that you only make him talk, but actual operative surgery assessment doesn't go on. And for that, we have to develop some tool, at the same time not compromising the patient safety. Some of the solutions which we are trying to talk about would be in those papers, would be the low HDI countries having partnership with the high HDI countries, so that what is not available here may be made available. But this was the conclusion by the authors who were written in 2015 on that. But to tell you, as far as India is concerned, we are neither on this end or the other end. For example, we have got all the facilities available in our country, what is available in any developed country, but unfortunately the number is less and the variety is so much and there is no uniformity. So what is probably available in A city is not available in B, and vice versa. So that is the only thing which is happening today in our country, and there is no policy maker who has told this is what is to be here, and who has to regulate that is another bigger issue today. And for overcoming that, they have suggested some of the online programs. This is the Society of Surgical Oncology in USA, which is giving such online programs for the surgical oncology trainees, so that at least even after completing the curriculum, they can update themselves. This is self-teaching. Modules have been developed. Such modules may or may not be useful everywhere, but they have developed. It's worth going through. And another question which always comes to my mind is curriculum-based training superior to non-curriculum-based residency programs? In the past, for example, I have gone through both. I have gone through residency program also, and later on the MCH program came in, which I took. But I always feel the non-teaching, non-curriculum-based programs like residency programs are one-way superior, mainly because of the flexibility it has got, that it has not got an exam on your sitting on your head, but you actually learn out of passion the surgery as well as the surgical skills. On the other hand, there is no evaluation. Whereas if you go to a curriculum-based training, there is definitely evaluation, both internal and external. But the problem here is the trainee is under stress only to take the examination rather than learning the nonsenses of what he should be doing. So we will have to take both the trainer's perspective, the trainee's perspective, and more importantly, the patient perspective before we make policies to overcome the deficiencies and lacunae which I was talking about. Thank you very much. It was a very short time to cover the whole area, but I thought I will just throw some pearls so that people will give us, at least I would take from you your advice, how to go about standardizing what I was trying to say is not uniform. Thank you very much.